You guys are going to tell me that. We have discussed lobar pneumonia in very detail. So basically, you are going to see involvement of your complete lobe, lung lobe, right? Which we have discussed. We have three lobes in your right side or two lobes on your left side. Okay, so you are going to see involvement of the complete lobe. Can you just tell me the bugs associated with lobar pneumonia? Most common.
Streptococcus pneumonia,
Okay, strep pneumonia. Okay, another
Staph aureus.
Klebsiella.
Haemophilus influenza,
Klebsiella. Okay, H influenza. Okay, so basically we are going to see certain phases of lobar pneumonia. Yesterday we have discussed congestion. What happens in congestion?
Increased permeability.
Increased permeability. Why? Due to neutrophil recruitments. Neutrophils are going to increase the permeability.
Yeah.
Okay, what happens? Your red blood cells are going to move outward, out from your blood vessels. As a result of that, fibrin is going to be let down. So what would be the next phase?
Red
Red
hepatitis.
hepatization.
Red hepatization. It resembles the liver. Yes, so you are going to see neutrophils exudates. You are going to see hemorrhagic filling of alveoli. That is hemorrhage or presence of red blood cells. Fibrin is going to just harden this exudate simply. You are going to see, okay, the macrophages and inflammatory cells are going to remove the red blood cells. So what would be the next phase?
Gray
Gray
hepatization.
hepatization.
Gray hepatization, which indicates that the red blood cells are going to be removed from this exudate. It would be still hard. That's why we are going to give it a name of hepatization. So gray hepatization, the red blood cells are going to be removed. The last phase, what happens?
Resolution.
Resolution.
Resolution. Which cells are involved in resolution? What do you guys think? Complete resolution.
Type 2.
Type 2
Macrophages.
pneumocytes.
Type macrophages and type 2 pneumocytes. Perfect. So other type of pneumonia which we will be discussing is your broncho pneumonia. What happens in broncho pneumonia?
Inflammation of bronchioles.
Bronchioles.
Okay, that are just around the bronchioles simply. Same inflammation going on around the bronchioles. Okay, and it can be caused by a variety of organism. For example, some bacteria, which we'll be discussing in a chart in the further discussion. Okay, you have another kind of pneumonia that is interstitial pneumonia. It's also known as atypical pneumonia or walking pneumonia.
Walking pneumonia.
So what do we mean by walking pneumonia? Simply, these kind of individual would mostly be asymptomatic with some mild upper respiratory tract infection symptoms, right?
Right.
Again, you are going to see diffuse interstitial infiltrate, and it can also be caused by some bacteria and viruses. Third pneumonia, which we have discussed yesterday, aspiration pneumonia, lung abscess. Which bugs are going to be involved? Okay,
Bacteroidetes bacterium.
bacterioids, fusobacterium,
Streptococcus.
and peptococcus, peptostreptococcus. Okay, the which kind of individual are prone to have aspiration
Alcoholics.
pneumonia? Okay, perfect. Alcoholics.
Caesar.
Okay,
Seizures.
loss of consciousness, coma, seizures. Perfect. So you are going to see an MCQs related to it. They will just tell you that we have found the bacterioid that is fusobacterium, and which like this individual is mainly having some seizures. Simply, okay. So now let's discuss each and every bug in detail. Okay. So the first bug which we are going to discuss here is Streptococcus pneumonia. It is going to cause community acquired pneumonia, right?
Right.
Yeah.
Okay. In which individual? That is middle aged and elderly. Okay. Secondly, we have Klebsiella pneumonia. Okay, you are going to see a pneumonia in the Klebsiella infection. Yes, hospitalized patients. All malnourished patients, alcoholic, diabetics. Okay, what do you guys know about current jelly sputum? What is current jelly sputum? One of your UWorld MCQs. In
Bright red.
Klebsiella infection.
In Klebsiella, we cough like currant jelly sputum.
Okay, why? Because this bug capsule, you have thick mucoid capsule. So, for example, if a person is having infection with Klebsiella, his sputum would be gelatinous due to the presence of this thick mucoid capsule. So that's why you are going to see current jelly sputum simply. Okay. Staph aureus. It's the most common cause of secondary pneumonia. What do we mean by secondary pneumonia?
Post-viral.
Okay. So for example, if we have a bacterial pneumonia, and upon that we have some viral upper respiratory tract infection. We already have some bacterial pneumonia, and upon that we have some upper respiratory viral infection. It's basically known as secondary pneumonia. So Staph aureus is most common cause of secondary
Post-viral.
pneumonia. Although there are certain other bugs. Okay, H influenza. It also causes secondary pneumonia. Remember,
Mm-hmm.
but in COPD patients mostly. Okay, and okay, you guys are going to tell me cystic fibrosis patients. They are also related to one of the bug. One of your you will answer.
Pneumocystis jirovecii.
Pseudomonas.
Okay, okay,
Pseudomonas.
that is Pseudomonas
Aeruginosa.
aeruginosa.
Mm-hmm.
Okay, then you have Legionella. That is Legionella pneumophila. Have you guys done the micro portion?
Yeah.
Yes, immunocompromised. Remember, transmitted by via water,
Mm-hmm.
poor contaminated water resources. Okay, they can also cause community acquired pneumonia, predisposed to COPD patients. So kindly, like I would just say that you guys should do it from, uh, like in the microbiology section in detail. Here we are going to discuss some of the like overview of this organism. Okay, Mycoplasma pneumonia. Okay, it's most common cause of atypical.
Pneumonia.
Atypical pneumonia.
Yes, guys, please participate. Which kind of individuals are prone to have mycoplasma pneumonia?
Elderly.
Yes, military and students who
Military
live in
people.
dormitory. Right?
Mm.
It's also associated with one of your hemolytic anemia, if you guys remember. That is warm and
Mm,
cold.
yeah.
Cold. That is
Cold.
IgM associated.
Yeah.
Okay. Then we have chlamydia. Chlamydia also causes atypical pneumonia.
Mm-hmm.
Guys, do it from microbiology
Yeah.
section, then you guys will be able to know the details. Okay. So don't worry, those who don't know the details, don't worry about that. You are going to cover it in detail in the microbiology section. Okay. Then we have Coxiella burnetii. Okay. Remember, guys, Q fever. Have you guys done the microbiology of these bugs?
Yeah, some I
Some of
have,
them, not
not
all.
all.
Okay. So it's going to cause Q fever in which community of people? Yes, sheeps, farmers. Okay. So now let's discuss another condition, that is tuberculosis. Still, you are going to do the tuberculosis as well in detail while you do your microbiology, but here we are going to do little details of TB, tuberculosis. Okay, so you have primary tuberculosis. Yesterday we have discussed primary tuberculosis. What happens in primary tuberculosis? Bug is going to enter, it's going to attack macrophages. It have a virulence factor. What's the name of that virulence factor?
Cord factor.
Cord
Cord
factor.
factor. Okay, TB is associated with which kind of occupational exposure?
Silica.
Disease. Yes, silica. Okay, so what do cord factor do?
Inhibits immune
Inhibits
reaction.
phagocytosis.
Okay, inhibits phagocytosis to form. So what happens as a result of that? You are going to see, okay, upper lobes or lower lobes, primary?
Lower
Lower
lobes.
lobes.
Lower lobes. Okay, you are going to see formation of Goon complex. What is Goon complex? The macrophages are going to surround it along with involvement of the hilar lymph nodes. Collectively, they are known as Goon complex. Simply. Okay, what if, okay, you are going to see positive PPD test. What is PPD test?
Purified protein derivative.
Purified
Protein.
Protein.
protein derivative, right?
Yes.
So basically we inject it in uh, like for example in a patient, and we
Intradermal.
if this person is having some, if this person is having some latent infection, or or he had TB in past, so what happens, he already have some like memory cells, simply you can think it of. Okay, so as a result of that, if I am just taking some portion of this TB bug and I inject it under his skin, so after 48 hours I will be seeing some inflammatory response. Simply, this is your PPD test, right?
Yeah.
Hello.
Yeah. Yeah.
Okay, what's secondary TB?
Reactivation of primary.
Reactivation of the
Okay, reactivation. What are the factors which reactivate this condition?
Immunocompromised.
Immunocompromised.
Okay, immunocompromised. Okay, which lobe is going to be involved and why?
Upper lobes.
But
upper lobes.
because of
Upper.
more oxygen.
More
Okay,
oxygen.
oxygen is more and lymphatic drainage is less. Okay, so what happens then? It can also spread hematogenously. Where?
Spine, bones,
Okay,
Fine.
vertebra. It can go to GI tract. It can also go to where, guys?
brain.
Okay, it can also go to brain. So, okay, so okay, and what would be the symptoms associated with a person having TB? Most importantly,
Fever, night sweats, weight loss.
fever, night sweats,
Weight loss.
weight loss,
Cough with
and
sputum.
Cough.
okay, cough, hemoptysis. Okay, which kind of response is it? TH1 or TH2?
TH1.
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 Okay, you are going to see formation of granulomas, right?
Right.
Yeah.
Yes.
Caseating or non-caseating?
Caseating.
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 Caseating granulomas. Perfect. So now let's discuss COPD, which we have already discussed yesterday, I guess. COPD, chronic obstructive pulmonary disease. So you guys are going to tell me what happens to FEV1,
Decrease.
Decrease.
what happens to
Decrease.
FVC,
Decrease.
Decrease.
which one
Decrease.
is decreased more?
FEV1.
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 Okay, what happens to their ratio?
Decrease.
Decrease.
Decrease then 0.8.
Point 0.8.
Yes.
Okay, so what happens to the total lung capacity?
Increase.
Increased.
Why?
Because
Air
air
trapping.
trap.
Air trapping.
Because of
Okay,
high
trapping of
volume.
air. Perfect. So, the first condition which we will be discussing, yesterday we have already discussed it in very detail, chronic bronchitis. Read index. What happens in chronic bronchitis? What's the cause? The main. Okay,
Smoking.
smoking.
Inflammation.
Smoking.
Smoking.
Smoking. What do smoking do?
Inflammation of
Hyper.
Trophy.
Okay,
Inflammatory scar.
inflammation of.
Mucous glands.
Okay, mucus gland simply. So what happens as a result of that?
Hyperplasia of mucous glands.
Hypertrophy or hyperplasia of mucus gland. What happens? He is going to say that I am just producing tons of mucus since last 3 months from 2 years, minimum of 2 years of history,
Hmm.
and at least 3 months prior. Simply. Okay, so you are going to see increase read index. What's read index? One of your UWorld and MCQ.
Increased
Mucosa
mucosal.
plus lava.
Okay,
Ratio of
it's the
submucous
ratio of thickness of the mucus
Mucosa.
glands to the
to the
thickness from the
lamina propria.
epithelium to,
To the cartilage.
yes, to the cartilage. Okay, so read index is basically increase. That is like you can see more than
More than
60% of these
50%.
glands
Mm-hmm.
occupying the overall thickness. Okay, so for example, if this person is having increased mucus, so can you just tell me that what will happen to EPP, equal pressure point?
Towards the alveoli.
Towards
Yes,
Toward
alveoli.
the
it's
line.
going to move
Towards.
towards alveoli. As a result of that, you are going to see collapse. So basically, they are also known as blue blotters. Why?
Cyanosis.
Cyanosis.
You are
And
going to see cyanosis. Okay, why? Because of the mucus plugs. What are you going to see? You are going to see increase carbon dioxide and less partial pressure of oxygen and bloaters because of air trapping. They would be bloated simply. So it increased the risk of core pulmonale. Why? Hello.
Because there is
Hypoxia derived vasoconstriction.
Yes, oxygen is less, constriction and core pulmonale. Simply. Now let's discuss another condition, that is emphysema. What's emphysema? We have two
Doctor,
variants.
what's equalization pressure and what's happening in COPD?
Okay, so equal pressure point yesterday we have discussed. For example, in two cases you are going to see equal pressure point shifted towards alveoli. That is in emphysema. Why? Because for example this is your alveoli and you are losing the elasticity. Okay, if the elasticity is going to be decreased, it means the pressure during expiration, the positive pressure is going to drop down, right? So it would, for example, if you have 30 of positive pressure here, normally this elasticity like add a pressure, let's suppose of 10 to it, the collapsing pressure, right? For example, if I am just applying 30 plus 30 force in order to collapse this alveoli from outside during expiration, so plus 10 is going to be provided by this
Last
elasticity. So for example, if a person is having emphysema or if a person is having mucus plugging, so what happens? You are going to see only plus 5. It means that as the air moves along this alveoli, it's going to become less. Okay, like for example, it's going to become, let's suppose, 29, 28, 25. Once it approaches 30, that is equal to the outside pressure. So this is basically known as equal pressure point. So at this pressure, whenever you have equalization of pressure, you are going to see collapse at that pressure because both of these pressure are equal simply. So normally you do not see the collapse. Why? Because these equal pressure point in normal individual happens at cartilaginous structures, and cartilaginous structure cannot be collapsed. But what happens in this patient with emphysema, or if a person is having these mucus plugs, so what happens? It's decreasing the velocity of this air. So it's most likely for the equal pressure point to move towards alveoli somewhere here. So if I have equal pressure point somewhere here, it means it can be collapsed because it is a cartilaginous structure to prevent the collapse simply.
Okay, thank you.
Okay. So what happens in emphysema, guys? One.
distraction.
Destruction of
Alveolar.
alveoli.
Alveolar destruction.
Okay, first of all, smoking is going to give you which kind of emphysema? Century or pan?
Centriacinar.
Entry.
Century acinar. Okay, the smoke is going to enter alveoli. Macrophages are going to engulf that smoke particles. It's going to release an enzyme. What's that?
Elastase.
Elastase.
Okay, elastase is going to undergo
Degrade
destruction of
elastase.
your acinus. What's acinus? Your alveolar duct and your alveoli. So you are going to see laws of this elastin simply. As a result of that, you are going to list it under category of COPD. Why? We have already discussed. EPP is going to shift towards alveoli. So you are going to see obstruction when a person expires simply. Okay. Another variant of emphysema is, guys, tell me.
Panacinar.
Panacinor.
Okay, pan acinar, and it is due to
Alpha 1 antitrypsin deficiency.
Already.
what is alpha
Deficiency.
1 antitrypsin?
Anti-elastase.
Elastase.
Okay, so normally this is the balance between elastase and anti-elastase, which is your alpha 1 antitrypsin. For example, if I have less alpha 1 antitrypsin, which is formed inside,
Liver.
okay, liver. So what happens? I'm going to increase the activity of elastase, and ultimately I'm going to see emphysema simply. So so in alpha 1 antitrypsin deficiency, you are also going to see involvement of the liver. Like the liver can also become cirrhosis. For example, if the liver is
Cirrhosis.
producing the alpha 1 antitrypsin, but it cannot release, it would keep on accumulating inside your liver. Ultimately, it's going to lead into liver cirrhosis. Simply. Okay, so can you just tell me the clinical features associated with emphysema? Dyspnea. Why? It's still an obstructive disease. You're going to see less oxygen. Hello?
Yeah.
Yes.
Okay, they are
Pursed
basically
lips.
known as pink puffers.
Pink
Why?
puffers. They
Mm,
because of the
Now
pursed.
you guys are going to tell me they basically expire with their lips being pursed.
Mm.
Why? With pursed lip.
They try to retain the oxygen.
Perfect. So they are
Because
like
of the back pressure.
increasing the resistance in order to keep some volume at the back side in order to avoid that collapse of pressure due to shift of equal pressure point, right? So they
Right.
would be pink, like you won't be seeing any cyanosis.
Mm-hmm.
Okay, so these kind of individual, you are going to see weight loss in them. Why? It's simple. Yes, increasing work breath, or simply they are using more energy for the respiration. For example, if I am my lips are pursed, so it means I am using more energy for my expiration, or simply the
Mm-hmm.
inspiration and expiration both. So what happens? Energy is used and increase
Weight
uh,
loss.
weight loss. Okay, okay, you are going to see. Okay, if you are trapping air inside your lungs, so
Mm-hmm.
it's going to give you what happens to your anterior posterior diameter of your chest.
Increased.
This is also known as barrel chest.
Barrels.
Okay, so for example, obstruction during expiration, it can lead to hypoxia
Mm-hmm.
and cor pulmonale, right?
Right.
Okay, now let's discuss asthma. Okay, now you guys are going to tell me asthma is TH1 response or TH2 response, first of all.
TS2.
TH1.
two.
Okay,
It's
who
two.
said TH2?
I don't know the HM.
Who said
I
TH2?
Uh,
No one.
TS2.
Hello?
yeah,
Yes,
it's two.
it is TH2 response.
Yes. Mm.
Okay, so basically, what happens, for example, if a person is exposed to certain allergen, what happens? Allergen is going to come. It's going to, for example, let's suppose your antigen presenting cells. It is going to present it to CD4 cells. The CD4 cells are basically your helper cells, right? Hello?
Uh,
Yeah.
Hello? Okay, CD4 cells have two types, TH1 and TH2.
mm-hmm.
TH1 induces your simply your
Granular.
macrophages
Granular macrophages
or granuloma
interleukin gamma.
formation.
Mm-hmm.
TH2 your beta 1 your beta B cells
B
response.
cells. Mm.
So basically they are going to initiate your B cells response. You guys know B cells are going to convert into which kind of cells? Plasma
Plasma
cells,
cell.
right?
Plasma cells.
Plasma cells are going to, okay, the first antibody, one of your UWorld MCQ, the first antibody which is released from your B cells is
IgM.
IgM.
IgM. Perfect. Then you are going to see class
Class
switching of,
switching.
okay, which interleukin is involved in class switching?
Um.
IL-4.
I'll
Yeah. IL-4. Mm-hmm.
IL-4 is going to undergo class switching. As a result of that, what happens? You are going to see IgE, right?
Mm-hmm.
Okay, your
Yes.
mast cells, these IgE are going to come. They are going to sit upon the surface of your mast cells, right?
Mm-hmm. Yeah.
For example, if this person has re-exposure to that allergen would simply come, they would aggregate or they would cross-link these
Cross-linking.
IgE. As a result of that, the mast cells is going to dump their histamines, leukotrienes.
Leukotrienes.
Okay. And as a result of that, what happens? You are going to see asthma. What's asthma? Bronchoconstriction,
Bronchoconstriction.
inflammation, as we have inflammatory cells here, right?
Mm-hmm.
So, can you just tell me the clinical features?
Wheezing.
Okay, wheezing, perfect.
Dyspnea.
Dyspnea.
Right.
Okay. Okay, as it is a, it's an allergic response. Can you tell me the kind of cells which are
Type.
highly related to allergic reaction?
Eosinophils.
Mm-hmm.
Okay, perfect. Eosinophils. Can you tell me the interleukin which drives the formation of eosinophils? One of
Interleukin
Five.
5.
Interleukin
I'll
5.
IL-5. It's also one of your UWorld MCQs. They are going to test you on it. Okay, IL-5. So, okay. So in clinical features, you are going to see dyspnea, wheezing. Secondly, you will be seeing productive cough, right?
Oh,
And in productive cough, you are going to see eosinophil derived crystals. What's that called?
Charcot Leyden crystals.
Charcot crystal.
Yes, eosinophils crystals that are basically known as charcot
Charcot Leyden crystals.
leaden crystals. Very high yield. Okay. Okay. You are also going to see these some spiral shaped mucus plugs. What are that called?
Hirschman spirals.
Yes, that
Russian
are
spiral.
Kirschman's spirals. Okay. Can you guys tell me what is methacholine test?
M agonist.
Okay, it's muscarinic agonist. Perfect.
Mhm.
So, what happened?
Bronchoconstriction.
Induced
Yes, those people who are
bronchoconstriction.
having asthma
Instant.
or increased sensitivity towards muscarinic, they would just undergo bronchospasm.
With low dose.
So, yes. Now, let's discuss the last pathology associated with COPD is your bronchiectasis. Already been discussed. What happens in bronchiectasis? Simply, you are going to see
Permanent
permanent,
irreversible dilatation.
permanent dilatation. And what's the reason for having permanent dilatation?
Recurrent
Recur-
infection.
Recurrent infection.
Perfect. Recurrent infection. Recurrent infection associated with your decreased,
Mucociliary clearing.
yes, mucociliary clearance or or cystic fibrosis. Fibrosis, mucus plugs. Again, stasis, increased chances of inflammation. These inflammatory or recurrent infection are going to simply necrose your smooth muscle cells in the bronchi or bronchioles. So as a result of that, they would dilate permanently. Okay. Okay. So this was all about COPD. Now let's discuss restrictive lung diseases. Right? Hello.
Okay.
Yes.
Okay.
Yes.
Okay. Now let's discuss restrictive lung disease. So you guys are going to. Okay. What happens to your total lung capacity?
Decreased
Why?
Yes. Less air is
due to the
we drink less
pathology
air.
Due to fibrosis, right?
fibrosis.
Yeah.
Okay.
Yeah.
What happens to the FVC?
Decreased
Decrease.
Decrease.
Decrease. Again, why?
Decrease.
Because they
Because
have less
less air
air
in.
inside to begin with.
Yes, less air in, so less air out. Simply.
Hmm.
Okay, FEV1
Decrease.
Decrease.
decreased.
decrease. Okay, what happens to a ratio?
Normal.
Normal or increase.
Normal or
Normal
increased.
or increased. Perfect. Then 0.8. Okay, so now let's discuss the first condition, that is idiopathic pulmonary fibrosis. So what is idiopathic pulmonary fibrosis? It means we do not know why the fibrosis takes place, as the name indicates. So idiopathic. Okay. So basically the etiology is not known, or simply you can think of, for example, if a person is having some cyclical lung injury, you know, whenever there is injury at the end, you are going to see fibrosis, right?
Right.
Yes. So cyclical lung injuries can cause fibrosis and it can result in pulmonary fibrosis simply. Secondly, for example, with the use of certain drugs, for example, anti-cancer drugs, bleomycin, and if you guys remember amiodarone, it also causes pulmonary fibrosis. Guys, remember?
Yeah.
Yeah.
Have you guys done the pharmacology? Yes.
Yeah.
It's also going to give you some restrictive pattern of pulmonary fibrosis, right? For
Right.
example, some certain radiation therapy. So, what would you see on lung CT?
Honeycomb appearance.
Honeycomb
Yes, you
appearance.
are going to see honeycomb appearance. Like you, for example, this is your lung. Okay, sorry for this lung. So you are going to see certain like this honeycomb type of appearance, indicating fibrosis. Simply. Okay, and what's the treatment option for a person having fibrosis?
Lung transplantation.
Change their lung. Simply. Okay. Now let's discuss pneumoconiosis. Already we have done it in very detailed. I won't draw anything. You guys are going to tell me directly. Okay, pneumoconiosis. First of all, cold worker. Hello,
Carbon
poll worker.
particles.
Okay. What's the color of lung?
Black.
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 If associated with rheumatoid arthritis, known as?
Kaplan
Kaplan
syndrome.
syndrome.
Capon
Okay.
syndrome.
Mild exposure of carbon.
Anthracosis.
Anthracosis.
Anthracosis. Perfect. Okay. Silica. In which kind of individual or in which occupational exposure?
Sandblasting.
Sandblasting,
Sandblaster.
foundry,
Perfect.
mine runs.
Mining.
Okay. Which lobes? Lower lobe, upper lobes?
It's upper lobe.
Upper lobe.
Upper lobe.
Upper
Eggshell
lobe.
calcification. Remembered yesterday?
Yeah.
Yes.
Yes.
Yeah.
Okay. Its
Increased risk of TB
pathophysiology is similar
infection.
as that of?
TB.
Tuberculosis.
Perfect. How? It would just disrupt the formation of Shogel lysosome.
Pagolysis. Yeah.
Okay. A person is having in aerospace industry and he developed non-caseating granuloma along with involvement of
Beryllium.
hilar.
Beryliosis.
Perfect. Berylliosis. Okay. So it increase. Okay. For the most common kind of cancer caused by asbestos.
Bronchogenic
Removal.
carcinoma.
Bronchogenic carcinoma.
Bronchogenic.
Perfect. Okay. Which kind of individual are exposed to asbestos?
Insulation workers. Like
Insulation.
Okay,
Insulation
those
workers,
working in construction
shipbuildings.
workers, plumbers, shipyard workers. Perfect. The only cause of
Mesothelioma.
cancer. Perfect.
Mesothelioma.
Okay, you are going to see ferruginous bodies. What are ferruginous bodies in the plura?
Asbestos fiber surrounded by
Asbestos
iron and
surrounded by
nickel.
particles.
Perfect. Now let's discuss sarcoidosis. Already discussed yesterday, so we are going to have a quick overview of sarcoidosis. Which kind of granuloma? Caseatic, non-caseatic?
Non-caseatic.
That's
Non-caseatic.
alive.
Non-caseated.
Okay, so it is alive. In which kind of individual?
Black.
What's the etiology? African American,
Female.
female.
Immunocompromised.
Young female.
American.
Black.
Perfect. If we have
Yeah.
granuloma formation, so type 1 hypersensitivity, type 1 or Th1 cells or Th2 cells?
TH1.
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 Perfect. You are
H1
going to see
cells.
involvement of hilar lymph node, right?
Yeah.
Yes.
Okay.
Bilateral.
We are going to see hypercalcemia. Why?
Increase in 1 alpha
Increased
hydroxylase
alpha-1
activity.
Yes,
hydroxylase
1 alpha
activity.
hydroxylase. Okay, what's the treatment option? One of your UWorld MCQ.
Glucocorticoid.
Glucocorticoids.
Glucocorticoid or steroids.
Prednisone.
Perfect. Okay, increase ACE activity. It can also invade other organs. For example, in the skins, it's going to give you
Skin.
which erythema? What's the name of that?
Erythema
Erythema
nodosum.
nodosum.
Martinet.
Perfect. If it invades your lacrimal glands and it destroys the lacrimal glands and salivary glands, what's that syndrome basically called?
UVIT.
UV.
Sjogren's syndrome.
Sjogren's.
Perfect, guys. You have just made it very easy. Okay, thank you. Okay. Okay. So now,
Hello, Dr. Ahmed.
yes.
Uh, so sorry for interrupting you. Ask the question. Are we going to have task tomorrow?
Yes, you are going to have task tomorrow.
Okay. Which system are we going
We are
to start?
we are going to start immunology, and today I'm going to send the schedule, and inshallah we are going to cover it in 3 days. Okay.
Okay. Thank you.
Thank you, doctor. Yes, 3 days.
It's gonna be hectic.
Okay. Yes. Okay. I'm planning to take a class for the tomorrow. Let's have a boot camp of immunology, and then you can just practice your MCQs. What do you guys think? It would
Yes,
be a
yes,
DL.
Of immunology?
Yes. Yes.
Tomorrow.
What do you guys
No.
think?
No.
Yes,
Too much. It's crumpy.
Like this boot camp
Easy
would
for
be
us to.
okay. This boot camp would be of 3 days. We are going to do in very detail each and every thing. Don't worry about that. It won't be like this.
Okay.
Oh my
So just
goodness.
when can we have the explanation of all the assessments? When you will send that?
Okay, so I have already sent to some of your colleagues. So I am having some issues with the editing type. Dr. The Futures already know I have the explanations, but I'll share it soon.
For all the assessments which we have done up till now?
Yes, all of the assessments.
Doc,
Okay, so
when
now
we're gonna have the pulmonary exam?
you are going to have what?
Exam link for the pulmonary.
Okay, so pulmonary we are going to start the assessment today. Okay.
Thank you so much, Doc.
Yes. So now let's discuss pulmonary hypertension. Okay.
So, doctor, when can
So
we? When can we have? Can you give us any rough idea for the detailed explanation of the assessment? Because as we are moving
okay,
forward, we don't have the previous one. So,
just give me a day or two because like I'm very busy in making these schedules and everything, so I do not get time for those editing and everything. So please ask me just some. If you guys want a raw document, I can share that, but it would be better to have a edited form of, and we can also have a session on that. Don't worry about that. Okay.
okay, but the raw one is also fine if you want to send me
So okay,
particularly the
today I'm going to
certificate.
share all of the raw documents.
Thank
Okay. So now let's discuss pulmonary hypertension. So you guys know what is pulmonary hypertension. For example, there are certain causes of pulmonary hypertension, one of which we have discussed thousands of times. For example, low oxygen. Okay, guys, just give me 10 minutes. Okay, sorry, I have some emergency. Just give me 10 minutes. Sorry.
Okay.
You have less space for the blood to flow or hypertension. The blood is going to exert a tremendous amount of force or pressure now, right? So it's basically seen in young adult female, right?
Yeah.
Hello. Okay.
Yes.
Okay. Okay. Or what? For example, if a person have some kind of pulmonary embolism, so would we see hypertension in them? Pulmonary hypertension.
Yes.
Okay. Why? Why?
Bad.
Hello.
Bad.
You guys are sleeping. Look. For example, if a person is having pulmonary embolism, again we are going to see pulmonary hypertension.
Because of the bad
Yes.
pressure.
Okay. So now, yes, you are just simply occluding it. It means you are increasing the resistance. So as a result of that, you can experience pulmonary hypertension simply. Now let's discuss a condition that is ARDS, acute respiratory distress syndrome. We have already discussed its details too. You guys are going to tell me what are the causes of ARDS.
Sepsis.
Okay, so what happens? You are going to see increased cytokines release. Okay, during sepsis, pancreatitis,
Burn,
Aspiration.
trauma.
Pneumonia.
Drowning.
okay, aspiration, trauma. So what happens, for
And
example, if I'm having more cytokines, what happens to the lung?
Increased permeability.
Increase
Increased
neutrophil.
permeability. For example, if the permeability is increased, then
Increase in neutrophils.
protein leakage.
Leakage of fluid.
Intraalveolar
okay,
membrane. I remember.
okay, you are going to see neutrophils recruitment, right? Leakage of the fluid. You are going to see hyaline membrane.
Yeah. I remember. Yeah.
Okay, so what happens to the surface tension?
Increases.
Increase.
Okay, so surface tension is increased because you are disrupting the, here the surfactants, right?
Yeah.
Okay, so
Sep-
on chest X-ray, you are going to see white out on chest X-ray, right? So it can be due to sepsis, due to certain infection, DITs. Okay, so activation of neutrophils induces protease-mediated free radical damage. These neutrophils are going to, the neutrophils have an enzyme that is, what's the name of
Elastase.
that? NADPH something.
Matrix metalloproteases.
Yes, matrix metalloprotease, and it also have another enzyme that we see in granulomatous.
NADPH.
Yes, NADPH. Okay, so it's basically forms some free radicals, right? Which we'll be discussing in the immunology section, the details of this. So, what happens as a result of that? These free radical can simply damage it. permeability is increased. As a result of that, hyaline is going to leak out. It's going to form this hyaline membrane. So a person would be in distress because you are disrupting the surfactants or surface tension is going to increase. So for example, after some time, what happens? You are going to see scarring and fibrosis. Hello?
Yes.
Okay. So neonatal respiratory distress syndrome, we have already discussed it. We will be just doing an overview of neonatal respiratory. What happens in neonatal respiratory distress syndrome, guys? Just be
Decrease
quick.
Decrease
surfactant.
surfactant.
Decrease surfactant.
Okay, decrease surfactants. Okay, what are the reasons of having less surfactants?
Prematurity.
High
C-section or
insulin,
maternal
prematurity,
hygiene.
decreased stress.
Cesarean
Okay,
section.
okay, perfect. Okay, so this was all about ARDS. Okay, now let's discuss lung cancers. So, what's the common cause of lung cancer?
Smoking.
Smoking.
Okay.
Smoking. Okay, and other risk factors? Asbestos. Remember, guys, the most common cancer caused by asbestos is what?
Bronchogenic
Bronchogenic
carcinoma.
carcinoma.
Radiation.
Yes, so
Radon.
asbestos can also be okay. Radon. What's radon basically?
It is a gas that is found in nature.
Yes, it's a colorless gas that is basically released from uranium decay. And basically those individuals living in some basement areas are going to have exposure to these gases. One of your UWorld MCQs, right? You have a scenario related to radon. Okay. So what would be the symptoms or the constitutional non-specific symptoms associated to lung carcinoma?
So, doctor, what is the common
Weight
cause
loss.
of carcinoma,
Weight
smoking
loss.
or asbestos exposure?
Sorry?
So, if the MCQ comes there, what is the most common cause of lung cancer? We will
Common
opt
cause is
for
smoking.
smoking or
Smoking.
asbestos.
85% of lung cancers are due to smoking.
So, what about asbestos? Asbestos is also not
Asbestos, it can also be one of the reason of lung cancer, not common cause.
but it's
Okay.
specifically for bronchopulmonary.
Sorry.
Asbestos is specifically the most common cause of causing bronchopulmonary, right?
Yes. Okay. So, okay, you are going to see cough, right? Weight loss,
Yes.
hemoptysis. Okay, we have already discussed the details of each and every cancer. So, first of all, let's discuss. Okay, small cell lung carcinoma. Which treatment? Resection or chemotherapy?
Chemotherapy.
Chemotherapy or
Okay,
radiotherapy.
or radiations. Perfect. Large cell lung carcinoma.
Surgery.
Surgery. Okay, what do you guys know about Pancoast tumor? What are Pancoast tumor, by the way? Yes, for example, if the superior sulcus is involved. So, what can it like? You can also see certain obstruction due to Pancoast tumor.
Yes, it can compress different structures, and from that it causes different
Superior
Horner
vena cava,
syndrome.
right? Superior vena cava syndrome. Secondly, you know the sympathetic chain also runs here in close proximity to lungs. So it can cause Horner syndrome.
Horner syndrome.
Okay. So now let's discuss each and every carcinoma. I won't be drawing again because yesterday we have discussed carcinoma. Okay. Small cell lung carcinoma. Association. It start from S.
Smoking.
Okay. Centrally or peripherally?
Central.
Central.
Yes. Okay. Which kind of cells are going to be present?
Small cells.
Chromat.
Okay.
Neuroendocrine.
Neuroendocrine. They are going to release certain hormones. Which hormones?
Release
SCTH, giving you
ADH.
Cushing syndrome.
Yeah.
ADH, giving you SIADH. You are going to see an MCQs related to these, okay? ADH,
Yeah.
Lambert-Eaton syndrome.
Yeah.
Okay. Squamous cell carcinoma. Characteristic histological findings, guys.
Desmosomes, intercalated.
Keratin pulse with presence of desmosomes, right?
Yes.
Okay. Yes, that intracellular bridges. Intercellular bridges, basically. Okay. So, Association starts from S.
Smoking.
Smoking. Centrally or peripherally starts from S.
Center.
Centrally. Which hormones associated with?
PTRP.
Okay, related.
Related
Perfect.
peptide.
Peptide.
Adenocarcinoma. Histological findings.
Granular
Increase in
Sense of
mucus.
mucin. Perfect.
Mucin.
Mucus. Okay. So associate. Okay, perfect. Peripherally, and it's also most common cause of cancer in United States
Non-smokers and females.
and non-smokers and females. Okay.
Females.
Large cell carcinoma. Everything is absent.
Hmm.
Like no keratin pulse, no glands, no mucin,
Poorly
no neuroendocrine.
differentiated.
Pleomorphic giant
Yeah.
cells.
Yes,
Poorly
poorly
Differentiated
differentiated
cells.
pleomorphic cells. Associated with smoking, right? Can be centrally or peripherally. It has poor prognosis. Okay.
large
Mhm.
Okay. So now let's discuss carcinoid tumor. Histological findings.
list of endocrine cells.
Chromogranin positive, it means you have neuroendocrine cells. It's not related to smoking. Okay. It can be centrally or peripherally as well. Okay. So this was all about cancers. Okay. Just give me a second. Okay. Let me open these slides. Okay, guys. So tomorrow we are going to start immunology. Okay, and I am planning to have a class just before we are going to have 2 hours of class on immunology, right?
Hmm.
Are you guys comfortable with that?
Yes.
Yeah.
Yeah.
Okay.
Yes.
Yes,
Yes.
doc.
Okay. So we will be doing it in quite detail, not like this boot camp. Okay, like we are. It's just for like a kind of revision. Okay.
Okay.
So now let's discuss our last topic, that is flora. So you guys are going to tell me pneumothorax. Already we have discussed it. Okay. So what is pneumothorax?
Air
Air
and blood.
in
Air
Air
into
into
space.
space.
Intra.
Pneumothorax, air in the cavity. What are its types?
spontaneous
Spontaneous and
Primary,
tension.
tension.
secondary.
Okay, primary spontaneous. What happens in primary spontaneous? Which kind of individual?
Marfix.
Young.
Tall.
Tall,
Young,
thin.
thin, tall,
Tall,
And
thin.
tall.
Okay,
Smokers.
male,
thin, tall,
male.
subpleural blebs. They are going to rupture.
Mhm.
If okay, second, your association with COPD, cystic fibrosis. If they are ruptured, it
Yeah.
can give you spontaneous. The trachea would be deviated towards the lesion or away from the lesion. In
Towards the
spontaneous.
lesion.
Towards.
Perfect. Okay, what happens in the tension pneumothorax?
Unidirectional
Opposite
valve is
flap.
Okay,
Deviation
yeah,
from the.
you have a flap, air is entering, but it cannot exit out.
wall. Yeah.
It means you are building air. Okay, we are going to see some um, like gases beneath the skin. What's that called?
Skin.
Subcutaneous
Crepitus.
crepitus.
Crepitus. Perfect. So the trachea would be deviated towards or the away
Opposite.
Away.
Away.
Away
opposite,
from the
because it's
skin.
going to apply pressure on the trachea and it's going to move in opposite direction, right?
Right.
Yes.
So now let's discuss our last topic, that is mesothelioma. So what's mesothelioma?
Malignancy of the pleura.
Okay,
Mesothelial
pleura
cells.
mesothelial cells. Okay, you are going to see chest pain, pleuritic chest pain, right? And what's
Yeah.
the only cause of mesothelioma?
Asbestos.
Asbestos.
Asbestos. Okay, so this was all about pathology. Hope I haven't missed any topic. So guys, I was just making pharmacology slides for today. So what if we discuss pharmacology tomorrow? What do you guys say? Like the
Okay.
slides are incomplete. I have just took some slides from the, the board and beyond, and some important like high yield. Some of the slides from
Okay.
uh,
Okay.
Pixarize. So we are going to discuss
Okay.
asthma drugs tomorrow,
Okay.
right before starting our immunology, right?
Okay.
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 Hope so
Okay.
you enjoyed today's boot camp. If you guys enjoyed, kindly give me a feedback in group,
Yeah.
okay?
Dr.
Okay.
It
Ahmed?
was
Yes.
Yeah.
Blood. 3 days or 2 days for immunology, then we are going to start blood because it's highly related with your immunology concepts, right?
Yeah.
And in
Yeah.
immunology, we'll be covering our third chapter of pathoma too. The first three chapters from pathoma are very high here. So immunology, I am doing immunology with you guys because we are going to cover immunology from pathoma as well as from first year.
Okay, doctor, are we having classes on Sunday?
Sorry,
Are we having classes on Sunday, this Sunday?
yes.
are we what? Sorry, I didn't understand. Sorry.
He's asking,
Are we
Again.
having classes
will you be
this
taking
Sunday?
class on Sunday?
Yes, you do not have any catch-up days. You have already consumed all of your catch-up days.
Oh, okay, okay.
No catch-up days.
Oh my God.
Yeah.
Okay.
Yes,
Dr. Ahmed?
don't think of catch-up days.
Oh
Yeah.
my God.
Okay.
Okay, okay.
Dr. Ahmed, can I
Yes.
yeah, can I make a small suggestion? Uh,
Small what?
yeah, I would like to make a small suggestion actually.
Sure, sure.
Yeah, so Dr. Ahmed, it will be really, really helpful if you could just include like histopathology slides or some X-ray findings also during the
Okay.
lectures. Yeah.
Okay. So, okay.
It will
So
be
we are
really
going to.
helpful if we have like if we see and if we have access to like a lot of images, because while solving the questions like most of the histopathological slides are very much classical of that particular disease. So
Yes.
yeah, if we are very much familiar to that the histopathological slides.
Dr. Renu, I'll try my best, but the best thing would be if you
Mhm.
remembered about we have discussed an idea of doing MCQs. Like, if you guys help me with that, I'll just
Mhm.
teach them. You guys just if you guys help me with collecting all of those slides, like I will try my best to
Yeah.
integrate those in
Yeah,
the end.
we are doing the MCQs and everything, but it's just that when you see the slides, so it takes less time to reach to the correct answer.
Yes,
That's
yes,
what
you
I
are right.
have noticed, yeah, while
Okay,
solving the MCQs.
okay. So from now onwards, in the remaining systems, I would just integrate each and every slide. But one
Hmm.
we are left with, you guys are going to help me with that. Okay,
Okay.
as you guys help me here. Okay,
Yeah,
it
yeah,
can't be done without your help.
absolutely. Yeah,
Okay, so hope you guys enjoyed.
yeah, yeah.
So if
Amazing
any
session as
questions,
always. Yeah.
yes, if you have any questions, you guys can ask.
Okay. Hmm.
Okay, thank you.
Thank you. Just give me a
Yeah.
feedback, okay? I'll be there in group.
Okay.
Sure,
Okay,
sure.
thank you.
Thank you,
Thank you.
Dr.
Have a
Ahmed.
nice day.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, doctor.